non-invasive assessment of clinically significant portal hypertension in compensated advanced chronic liver disease. So there are so many words in this. I will try to make it simple. So I know this is a mixed group. There will be some who are specialists, some who will be generalists. So let me go with each topic. And so I will be talking about what is actually advanced chronic liver disease, what is then compensated advanced chronic liver disease, what is clinically significant portal hypertension, how do you assess this portal hypertension, and then how to assess it non-invasively, which is the main subject of our topic today. So you know that when it comes to liver disease, the basic underlying pathology, irrespective of the etiology of the liver disease, it is the fibrosis. So the fibrosis, there are 4 stages you would have read from your undergraduate medical days. The F1 is just the portal fibrosis. F2 is portal fibrosis with few septa. And then F3 is there is septal fibrosis along with portal fibrosis. And then cirrhosis is there is a complete nodule formation. Okay, so this cirrhosis is what we call as the end stage liver disease. So earlier we used to think that fibrosis is completely irreversible, but now we know that to some extent it may be reversible if we detect it early and we treat the etiology. So the cirrhosis is a very common problem, especially decompensated liver disease is a very common problem. But we had a very simplistic view of it. So from the time of my MBBS or even 10 years later, so this was a paper which was published in 2006. So this, when somebody has cirrhosis, we always try to put it in two compartments, whether it's a compensated cirrhosis or it's a decompensated cirrhosis. So decompensated cirrhosis means they will have ascites, jaundice, varicose bleeding, hepatic encephalopathy, or a HCC. So if they have any of these things, we say that they have a decompensated cirrhosis. But before that, they may have a compensated cirrhosis, and this cirrhosis may develop over a long period of time. And from the compensated cirrhosis, this may take some time to go into decompensated. So why is this important? Because this is very important for the prognosis. So your survival when you are in a compensated state is much different from your survival when you are in a decompensated state. So this is a classical study, which was again published in the same paper. So if you have a decompensated cirrhosis, that means one episode of ascites, one episode of jaundice or bleeding, that means your median survival, that means 50% of the people may not live beyond 2 years. Okay, whereas if you have a compensated cirrhosis, then your median survival, that means 50% of patients may live beyond 12 years. So this is the importance of knowing whether it's a compensated or a decompensated cirrhosis. So from the 2 compartment, now we have come to another 4 compartments. That means in the compensated state itself, I want to concentrate here, there is a 2 stage. That means those without varices and those with varices. So both of them have no symptoms, but those without varices, no varices, they have less than 1% chance of progressing of mortality. Whereas those with varices, 3.4%. That means even in the compensated state, if you have varices, you are not going to do so well. So this fibrosis, so that means if they have in every etiology, and this one study was published for NASH, so that it is the fibrosis stage, not just the inflammation part, which predicts the mortality. Okay, so that means, so if you have, F4 fibrosis, that means, it takes only 1 year for you to decompensate. Whereas if you are in F2 or F1, it will take, 10 to 15 years for you to develop any liver-related event. So the fibrosis is the most important pathology for liver disease. So now we come to our term, that is a compensated advanced chronic liver disease. So this is defined by the Baveno 6. So Baveno, we know, is they are the consensus group who are working on portal hypertension. So far, 6 meetings have been held and published. And in the last week of October, they had Baveno 7 also, but we don't have the publication yet. So patients, so this group comprises patients with chronic liver disease who are at risk of developing clinically significant portal hypertension. So this involves both F3 and F4, that means severe fibrosis and cirrhosis, because they are a continuum. They are both are asymptomatic, and clinically it is not possible to differentiate both. So currently we use this term as interchangeable: compensated cirrhosis and compensated advanced chronic liver disease. So how to identify this advanced fibrosis? So the moment we say the word fibrosis, that means it is a pathology. That means we need a biopsy. So liver biopsy is still the gold standard for the diagnosis. But we know that liver biopsy has its own, pros and cons. It is still an invasive method. It has an inter-observation variation and a small risk of complication. We can always also identify the advanced fibrosis by imaging like ultrasound or CT by large nodular liver, irregular liver, collaterals. If they have collaterals or ascites, that means obviously decompensated. Presence of low platelets or sometimes AST-ALT ratio in a reversed, that can also identify advanced fibrosis. So how to suspect this compensated advanced chronic liver disease? So now last 20 years, there has been enough and huge number of work which has been done in the transient elastography, and we have now guidelines and criteria which has been established. So the liver stiffness measurement by transient elastography now is used for identifying or suspecting this compensated advanced liver disease. So this is one algorithm which is published most recently by EASL 2021 June. So which is meant for mainly for general practitioners. So they will see lots of patients with fatty liver or hepatitis B. So when to refer the patient to a hepatologist or when to identify advanced fibrosis. So apart from checking all the blood parameters and then identifying the risk factors, there is one non-invasive marker which is used, which is called as the FIB4. So this has been, evaluated in multiple studies. So basically, it's very simple. It looks at the age, AST, ALT, and platelet. Online calculators are available. If it is less than 1.3, that means it is low risk. That means they are not likely to have advanced fibrosis. Whereas if it is more than 1.3, then there is a risk of advanced fibrosis. Then you subject that patient for liver stiffness measurement. And if it is less than 8, then probably it does not have. If it is more than 8, then we need further, whether biopsy should be done or what. So this is how we identify the advanced fibrosis. So I am not going into the details of transient elastography. If there is anybody wants to know about it, we'll talk about it later. Basically, this is a special probe is used and the shear wave is used and the speed at which it goes through the liver. So if it is a stiff liver, the values will be higher. And a stiff liver is a fibrotic liver. That's how it is used. And when you use this liver stiffness machine, so when to suspect the compensated? So the Baveno 6 that is published in 2015. So they have given clear guidelines to that. So there is always this rule in and rule out. So it is a spectrum. So it is not one single value. So if the liver stiffness value is less than 10, that rules out advanced liver disease. Whereas if it is more than 10, it is suggestive. More than 15 is highly suggestive of. So there is a rule out, that means less than 10 is rule out. There is a rule in. So more than 15, it rules in the advanced liver disease. So what is the next step? So now if you see a patient with high liver stiffness, yes, 15, it's 17, that means yes, he has high likelihood of advanced chronic liver disease. What next? So next step is to identify the portal hypertension. So that means because we know the portal hypertension is the main driver. So patient has cirrhosis, and then depending on the portal hypertension only, all the other complications will rise. And so we have to look for the presence of the portal hypertension. So let's say if I have a patient and somebody with chronic hepatitis C, and then one patient with alcoholic, one patient LSM is 17, another patient is 20, so we can suspect that he has a compensated advanced chronic liver disease. So what next? So the next step would be, one is the management of etiology. So if it is due to hepatitis B, hepatitis C, we have to give antivirals. If it is because of alcohol, we need to stop the alcohol. So we have to definitely tackle the etiology. And then next one, which was almost universal, was to do the endoscopic screening for high risk varices. Because if they have large varices, they are likely to bleed. And the chances of going in for further complication is also high. So this was what was standard. Okay, so we have to do an endoscopy. So this is what is now getting changed. So we have to do an endoscopy if we suspect advanced chronic liver disease. And then once we say a clinically sick port, we have to diagnose portal hypertension. That means how is this portal hypertension actually measured? So what we now how we measure this portal hypertension is using this HVPG. HVPG means hepatic venous pressure gradient. So this is an indirect marker, surrogate marker for the portal hypertension. So this is done by passing a catheter to the internal jugular vein and passing it into the right hepatic vein, and we measure the free pressure and the wedged pressure. and the difference will give us the hepatic vein pressure gradient. So this is a very important tool to exactly assess the portal hypertension. So in this, so when we say clinically significant hypertension, so we should know what is normal. So normal is 1 to 5. Anything more than 6 to 10 is called as mild or subclinical portal hypertension, but more than 10 we call as a clinically significant portal hypertension. This is what is a very important point we all should know. So if it is more than 10 means they are likely to develop complications, and more than 12 that means severe portal hypertension. So they are likely to bleed. All the other complications are there. So Dr. Nisha also will be talking about this, I think, in the when she's going to talk about surgery for HCC. So patient, whether if he has underlying cirrhosis or advanced fibrosis, how are we going to deal with hepatectomy? So this, knowing this portal hypertension is very, very important. So this is the same thing. So more than 12, the increased risk of rupture of varices. So now we know that the fibrosis is an important component, and then next we have to know the portal hypertension. So this fibrosis is the one which determines the hepatic resistance to the portal blood flow. So liver stiffness represents a surrogate marker of fibrosis. So same, this liver stiffness measurement we use to assess the degree of portal hypertension. So now numerous studies have been done in the last 15 years to assess the, whether we can use LSM to assess the degree of HEPG in clinical practice. So this criteria also has been published in 2015 by Benno-6. That means if your liver stiffness measurement is less than 20 and your platelet count is more than 150, that means you don't have to do varicose screening. That means your chances of missing a high risk varices is less than 5%. In fact, numerous studies have shown it to be less than 2%. So that means if we know that somebody has now an advanced chronic liver disease, but it is less than 20 and his platelet counts are more than 150, then we can try to avoid the endoscopy. But of course, we need to do a periodic liver stiffness measurements. And if one of them is not the right criteria, that means LSM is like 18, less than 20, but if the platelet count is low, again you have to do the endoscopy to assess the risk of varices. So there are many studies which have looked into it. I'm just going into 1 or 2 studies. This is from India, from Gangaram Hospital. So where they looked at the correlation of transient elastography with HEPG in patients with cirrhotic portal hypertension, 326 patients, and their cutoff value for identifying clinically significant portal hypertension was 21.6 with a positive predictive value of 93%. And there is systemic review, there's meta-analysis. In fact, 2 meta-analyses are there, and most of them have shown that transient elastography has a high accuracy and correlation. So for both for detecting portal hypertension as well as for detecting the clinically significant portal hypertension. And so now we go to the next step. Okay, so this HEPG is used in this for acute bleeds. What are the chances of rebleed? How to use this HEPG post tips. So this HEPG is not freely available everywhere. So they have looked at this study from AIMS. This is done soon after a bleed. So, what are the chances of rebleed? So where usually we use the HEPG. So they have done, in the post immediate, 1 to 3 days, what is the risk of rebleed? So what they have seen is post-bleed liver stiffness more than 30 and a baseline HEPG more than 50. This we all know before. They were optimal cutoff for identifying patients at high risk of bleeding. So we know that liver stiffness measurement can be used to assess fibrosis. We can assess advanced fibrosis or the compensated liver disease, and we can even assess to a certain extent the degree of rebleeding. Okay, it has also been studied for prediction of complications. So numerous studies are there. So liver stiffness more than 40. So they are more likely to develop decompensation than those with values less than 40. And then for prediction of post-operative liver failure. So if they have a very high stiffness, post-operative liver failure is high. Prediction of large versus small varices, 45 versus 26 kPa. Prediction of varicose bleeders versus non-bleeders. So, so to various degrees, it has been studied. So, but some word of caution. So the correlation between this liver stiffness and the HEPG is very good for the values of 10 to 12. So beyond that, it may not always correlate very well. The reason being is, so we know that the liver stiffness measures the liver fibrosis. So beyond some stage of liver disease, it is not just the portal hypertension alone. That is not the fibrotic modifications alone. We know that there is hyperdynamic circulation, there is collateral development, there is splanchnic vasodilatation. So all these will not be picked up by the liver stiffness alone. So we have to understand these caveats. And also some etiologies may have a slightly higher liver stiffness, like alcoholic liver disease may have a slightly higher liver stiffness than the viral disease. So this is a very recently published paper in 2021 from Seoul, more than around 500 patients. So they are along with liver stiffness. These are the other ways by which we can also liver stiffness to platelet ratio, liver stiffness to splenic diameter, though we are not commonly using it in the practice. So so they have looked at that, and what they have seen is that those with alcoholic cirrhosis, for detection of a clinically significant portal hypertension, they have much higher cutoff, like somewhere around 30s compared to other cirrhosis. So this needs validation in other studies. Why the alcoholic cirrhotic people may have higher liver stiffness? It could be because of the underlying pathology. So in alcoholic, there is centrilobular, perisinusoidal, and there is also some amount of steatosis and inflammation. So that may contribute to a higher liver stiffness. So this is one point we need to know. And this is another interesting study. So they have looked at patients who have admitted with with alcohol withdrawal. That means they have been taking alcohol up until recently, and they have done transient elastography as well as liver biopsy within the first 10 days of admission. So 300 patients. And what they have seen is stiffness less than 10 kPa rules out advanced disease. Stiffness more than 25 kPa, yes, it rules in compensated advanced liver disease by liver biopsy. And among the patients who are in between this 10 and 25, so what they have seen is they repeated this liver stiffness at month 1 and month 2. Okay, and if they have abstained from alcohol, so they see that it has dropped by more than half. From 21, it has come down to 11. So more than 50% of people who are abstained, it has dropped very well. Whereas people, if they continue to take, it continues to remain high. So the one interpretation of this test is that if you have a patient who is actively taking alcohol and he has come to you and now his liver stiffness is high, when to do the liver stiffness again? So whether like this high stiffness is because of the alcoholic hepatitis or not. So probably at 2 months, it is a good time to redo the liver stiffness study. Okay, so now I have told about the Baveno 6 criteria. That means liver stiffness measurement less than 21 and the platelet count more than 150. You don't have to do endoscopy. So whenever we have a criteria, then people are again working over it to modify that criteria, whether it can be made better, just like Milan criteria came in 96, and then we work on it to expand the criteria. So it has been done. So there's something called expanded Baveno 6 criteria, wherein they have tried to take LSM less than 25 and platelet more than 110. So that means what if we expand this criteria and try to avoid endoscopy for more patients? Yes, endoscopy could be avoided in more number of patients, but then there is also a chance that you may miss some amount of patients with high risk biases. So from the expanded criteria, they went to modified criteria. That means liver stiffness less than 25, platelet count 150. So all these have been studied, but still it is not freely accepted because the chance of missing is still high. I do not know whether this Baveno 7 may change all this. We do not know, but as of now it is 21 and 150. So the reason why the base criteria here is that with the present Baveno 6 criteria, we can avoid around 15-20% of endoscopies, but the number of missed high-risk varices should be less than 5%. So we cannot afford to miss more than this. Okay, so this is one study which was published very recently. So this is refining the Baveno 6 elastographic criteria itself for definition of compensated advanced chronic liver disease. So I told you in the beginning itself, so less than 10 rules out, more than 15 brings in. So this has a sensitivity of 75% and a specificity of 96%. So this study was done in 10 European centers, more than 5,600 patients, and they underwent liver biopsy as well as elastography. And what this study is suggesting is that if we use a slightly different cutoff instead of 10 and 15, sorry, instead of this cutoff, we liver stiffness of 8 to rule out, and liver stiffness of more than 12 to rule in. Okay, so this is just a study which has been published. We have to see whether Baveno is going to accept or not. So these are things we need to know, the evolving figures. Apart from the liver stiffness, much interest has been shown in splenic stiffness. So though we are not doing that routinely in our clinical practice, so splenic stiffness, so that is also a marker of portal hypertension. So less than 40 rules out portal hypertension, and more than 50 rules in the clinically significant portal hypertension. So I'm coming to the end of my talk. So we have this June 2021, this EASL guidelines on the non-invasive test for evaluation of liver severity and prognosis. So the definition as per this guidelines for the compensated advanced chronic liver disease is the patients who with chronic liver disease who are at risk of clinically significant portal hypertension. So it involves spectrum of both F3 and F4. Clinically, we cannot differentiate. And as of now, the cutoff is less than 10 rules out and more than 15 rules in compensated advanced chronic liver disease. The Baveno 6 criteria, that is, if your liver stiffness is less than 20 and the platelet count is more than 150, then probably the endoscopic screening for high-risk varices is not required. How accurate are these tests compared to endoscopy for diagnosing and excluding high-risk gastroesophageal varices? So this has now become a strong recommendation. So this is a validated tool. Transelastography is now a validated tool to rule out high-risk varices. Okay, so this is a strong recommendation now. How accurate are these tests for prediction of clinical decompensation, HCC, and mortality? So all patients with advanced chronic liver disease, the liver stiffness and diagnosis should be done, and probably a periodic or a repeated measurements also to be done to refine and the risk stratification. Thank you.
So the topic for today is going to be preoperative liver function risk assessment for hepatocellular carcinoma. A bit of a strange topic for a gastroenterologist, really, because this is more for a surgeon's forte. But if you look at it, you know, we are the ones who are going to refer the patients to the surgeon. So it's a good idea to have, you know, in-depth knowledge regarding which is the patient who can actually undergo surgery for a hepatocellular carcinoma. So HCC is the most common malignant tumor of the liver. It's the fifth most common cancer in men and eighth most common cancer in women worldwide. Men are affected more than women in high-risk areas, but the incidence is equal when it comes to industrialized countries. Distribution and trend is non-uniform, with an increasing trend in USA over the years. And we see that in Japan, initially the trend had been increasing till year 2000, and thereafter the trend has been reducing. So we look at the risk factors of HCC. So we have the major risk factors as hepatitis B, C, cirrhosis of any cause, and toxicity due to aflatoxin B. Other chronic liver diseases like hemochromatosis, that is without underlying cirrhosis, non-alcoholic fatty liver disease, Wilson's disease, glycogen storage disease type 1 and 2, type 1 hereditary tyrosinemia, alpha-1 antitrypsin deficiency, and membranous obstruction of IVC, and some other diseases which are not really linked to the liver. And these are hypercitrullinemia, ataxia telangiectasia, smoking, diabetes, and use of oral contraceptive pills. So surgical resection is considered the first treatment option for early stage patients. However, it is reserved for patients with solitary tumors without portal hypertension and a normal bilirubin. So obviously, it means that we have to catch our patients early. And to catch them early, the recommended testing for at-risk patients is going to be 6-monthly ultrasound abdomen and alpha-fetoprotein levels. And why is it important to understand that which is the patient who can undergo a surgery and undergo a resection? When I'm talking about surgery, I'm talking about resection surgeries. It is so that we can avoid the post-hepatectomy liver failure situation. Now, this post-hepatectomy liver failure is graded as grade A, B, and C, where in grade A, we require no specific treatment. In grade B, we require essential non-invasive treatment like giving albumin, FFPs, and daily diuretics. Grade C will require invasive procedures including mechanical ventilation, hemodialysis, and extracorporeal liver support. Perioperative mortality post-resection was defined as death within 90 days after liver resection. Now, what we need to understand is in most of these patients who have HCC, we actually have some underlying liver disease, and this might be a contraindication to surgery per se. Preoperative assessment thus becomes critical for these patients as it would be for any of the major surgeries, and it must include liver function assessment, medical comorbidities, blood pressure, ischemic heart disease, diabetes, the location of the tumor. That is very important. It may be absolutely subcapsular or it may be deep inside the liver. The baseline liver functions, tumor biology, that is high AFP levels, large tumor size, major vascular invasion, extrahepatic metastatic disease, and positive margins. So when we talk about the baseline liver function, a preoperative liver function evaluation is important to avoid postoperative liver failure, which will be defined by an increased INR, a concomitant hyperbilirubinemia on or after the postoperative day 5, as has been proposed by the International Study Group of Liver Surgery. So the result of the recent advances in surgical techniques and perioperative management, liver resection has become more and more safer and mortality rates have reduced, especially since we have been using laparoscopic techniques for resection. Aggressive surgical resection and repeated resection of HCC has been reported to offer a survival benefit, and more centers in the world are doing it. And also the presence of the three-dimensional 3D volumetric analysis has significantly contributed to precise surgical planning and safe hepatectomy. So let's go down to the basics of how we used to evaluate the patients of a liver disease for any surgery, the CTP scoring. So in 1964, Child and Turcott performed portocaval shunt surgery, initially developed a classification to predict postoperative mortality. And later it was first used to predict short-term and long-term outcomes in a report which was based on the data of only 38 patients who had undergone transection of the esophagus for bleeding varices. Now, neither this nor the Child-Pugh score were developed to predict patient outcome after liver resection. And at least 3 factors, encephalopathy, bilirubin, and ascites, are going to be normal in most of our patients who undergo resection for HCC purposes. Hence, the CTP score is really not of great value when it comes to resection purposes for HCC. Nevertheless, the Child-Pugh classification is still used in decision-making for liver resection because we have seen the child status B patients, they have a poorer prognosis as compared to child A patients with regard to both short-term and long-term outcomes. In most of the Western centers, liver resection is limited to child A status. Child B may not be an absolute contraindication for liver resection, but major liver resection is avoided in them and liver transplant is offered. Now, after the CTP score, the one which has now come in and is being used, in a lot of centers in lieu of CTP scoring is the ALB scoring, in which they are taking only 2 variables, albumin and bilirubin. And it was first proposed by Johnson et al., in which they proposed a new evidence-based objective liver function grading system based only on serum albumin bilirubin levels. In general, the grades 1, 2, and 3, they correspond to Child-Pugh A, B, and C respectively. However, liver resection for HCC is normally limited to patients with normal bilirubin. Therefore, the usefulness of the ALB score comes down to just the presence of the albumin, normal albumin levels or not. Now, recently, Wang et al. Reported that the ALB grade more accurately predicts post-operative liver failure rather than the CTP scoring. The plus point of the grading that was within the CTP grade A, 2 distinct prognostic groups, grade 1 and 2, could be identified in all with a median survival difference of nearly 6 months. And how do we calculate it? We calculate it using a Cox regression model. So the grades of ALB are as such. Grade 1 is a score of less than equal to minus 2.6. Grade 2 is between minus 2.6 to less than equal to minus 1.39. And grade 3 is when the value is more than minus 1.39. And as we can see, the median survival is reducing down the increasing grades. Patients with an ALB score above minus 2.77 had a higher incidence of post-hepatectomy liver failure than patients with scores of minus 2.77 or less. The LB score fallacy is the same as its benefit. That is, it takes only two variables into consideration. Now we come to the MEL score. So first I'm going to go with the old scoring systems which have been used. Then I will talk about the newer modalities which we are currently using, especially in our country. And then we are going to talk about certain modalities which are being used in some other countries, but not necessarily in India, in most of the centers, that is. Now, MEL scoring could be considered as an alternative to the CTP scoring. However, this was specifically designed for patients with end-stage cirrhosis, which anyways is a contraindication for liver resection. And serum creatinine is one of the parameters for MEL, may be less reliable in patients with the HCC because of cancer-related cachexia. The Mayo Clinic study showed that liver resection patients with MEL scores of 9 and higher had a significantly higher perioperative mortality to 9% versus 0% for patients with lower MEL scores, and also had lower 5-year survival rates. Now we come to portal hypertension, as was also talked quite nicely by Dr. Hema, that how we can predict portal hypertension. Routinely, as of now, in majority of the centers, we are still going for doing an endoscopy. We do use HVPG, measurements in the major centers of the country, but in most of the other centers where HVPG is not routinely available or affordable, we may have to rely still on the presence of just the esophageal varices, presence of splenomegaly with the platelets of less than 1 lakh. And why is it important to understand whether portal hypertension is present or not? Because we have seen that patients who have portal hypertension, when they underwent resection for HCC, they had a poorer outcome. So the positive thing here is that rather than doing an endoscopy, probably we can also at this juncture, maybe at least in near future, include fibroscan as a modality of understanding how significant is the portal hypertension before we can take up the patient for surgery. Now, while the group had claimed that portal hypertension is a negative predictive value, has a negative predictive value for outcome post-surgery, the same group also reported a systematic review and meta-analysis of about 11 studies examining this issue, and they realized that in recent times, portal hypertension is not really an absolute contraindication for the surgery, and liver resection is being done in HCC patients with portal hypertension in certain specialized centers worldwide. So the most recent ESIL guidelines do not consider portal hypertension to be an absolute contraindication for minor liver resection. And here you can see that increasing number of published series where actually resection has been done in HCC patients with a portal hypertension. So what do we mean by anatomical resectability? An HCC is technically resectable if it can be removed with negative margins while preserving a liver remnant with adequate hepatic arterial and portal venous flow, biliary drainage, and sufficient parenchyma to support the liver functions. So the concept of future liver remnant. The mortality risk after liver resection will increase if there is increased fibrosis and cirrhosis. What do we mean by future liver remnant? It is the proportion of the liver which is remaining behind when we go for a liver resection. And it is important that we have a significant amount of future liver remnant so that the liver function is not affected post-surgery. So it is calculated as a ratio of the standardized liver volume. So if we see that the FLR, the future liver remnant post-surgery, if it is going to be less than 20%, then we do not, less than 40%, then we do not take up the patient if he's a cirrhotic. It's 30% with an underlying fibrosis and 20% for a normal liver. In some patients, in some places, patients with a marginal FLR, they are recommended to have a preoperative portal vein embolization performed because this allows the surgeon to test the regenerative capacity of the liver prior to the operative intervention. So during the portal vein embolization, the particular vein branch which is supplying the part of the liver which is going to be removed during the liver resection, that is the one which is blocked. And we allow the blood supply to be diverted towards the remnant part of the liver, the healthy part of the liver, which is going to stay behind. And we allow for the hypertrophy of this part of the liver to occur. Now, this is going to take about a month or so. So the negative part is that a lot of people while they are waiting for the hypertrophy of the liver to take place, they can actually have the further spread of the malignancy, and it can render them inoperable. So that is the problem with that. So in comes in the situation that can we use something else along with the portal vein embolization. So yeah, people have tried doing transcatheter arterial chemoembolization along with portal vein embolization, so that we can have a greater amount of FLR available to us. And this also gives us a benefit that there can be a lower incidence of post operative recurrence of the tumor, and we have a higher amount of complete tumor necrosis. However, the chances of liver failure right after the procedure are also higher, because a greater amount of normal liver might get involved while we are doing the TACE. ALPPS, associating liver partition and portal vein ligation for stage hepatectomy. Now, this is done on the table by the surgeons, and we find that this leads to a faster and more FLR hypertrophy. And almost 75% in only 9 days was achieved by Schnitzler, who first reported on it. However, the negative part is that we have higher amount of morbidity, mortality, and early recurrence rate with this particular procedure. So what are the other parameters which make us understand that whether the case is operable or not, whether we can do the resection surgery on the patient or not, is using imaging like CT, MRI or PET CT to see extrahepatic tumor burden. And intrahepatic tumor burden also needs to be assessed using MRI, which is the preferred modality for determining the number and location of tumors, as well as relationship of the tumor to the major vascular structures within the liver. Intraoperative ultrasound is used to confirm the number and location of the tumor, as well as anatomy of major vascular structures within the liver immediately prior to resection. So we meet our old friend again, the Barcelona Clinic Liver Cancer Staging Classification and Treatment Schedule. This is the one which is used in majority of the centers worldwide. We also have the Japanese system. Some other systems had also come in, but they are not used much to a great extent, at least not in India. Japan, of course, uses the Japanese system. If we look at the BCLC, which is the one which we use, we find that the liver resection is actually restricted to stage 0 cases, and in stage A cases, wherein the disease is early, the nodules are less than 3 centimeters in size overall, or they are less than 3 in number. And you do not have the BCLC, of course, has always talked about no portal hypertension if you are thinking about going for a liver resection. And when it talks about advanced liver disease or evidence of significant portal hypertension, then it recommends going for a liver transplant. So we see that stage 0 post-resection 5-year survival rate is above 50 to 70%, and resection of HCC can be performed safely in non-cirrhotic individuals. However, the number of patients who have HCC and are not cirrhotic are really just about 5% of the overall caseload of HCC. And how can we avoid recurrence post-resection? Now, long-term survival after resection is curtailed by a high recurrence rate, 70% at 5 years, even when we select our patients pretty well. Pathological predictors of recurrence will be microvascular invasion, satellite lesions, and poor differentiation degree of the malignancy. Prevention of tumor relapse has been attempted with internal radiation with iodine-131, retinoids, or adjuvant therapy with immunotherapy, and including percutaneous ablation, chemoembolization, chemotherapy has been used as adjuvant therapy to avoid the recurrence. However, we still need more studies to understand whether this is going to be of benefit in the patients, or whether this should be the routine where resection is advised. Of course, when the patient is not resectable, we only have liver transplant to offer to our patients, especially for cases within Milan criteria. Now we also have we have the extended Milan criteria as well, wherein we can go in for the liver transplantation. But this is a different chapter altogether, and I will not be talking in detail about it. So the indocyanine green retention rate, ICG R15 at 15 minutes, that is. So this was first reported in English literature by Makuchi et al. And he used this to make a decision regarding hepatectomy, the section removals for various kinds of liver surgeries. Kibuta et al. Reported that portal vein embolization is indicated if the residual liver volume to total liver volume ratio is less than 40% in patients with normal liver and less than 50% with those with an ICG R15 value between 10 and 20%. In Western literature, Clavin et al. Proposed that an ICG R15 of less than 14% is the limit for major hepatectomy without portal vein embolization in patients with cirrhosis. So in a way, it has been used for understanding whether the patient can be taken up for surgery or not. Makuchi et al. Had also used, the injection on the table. He would inject the dye in the portal vein supplying this area so as to mark out the segment which could be removed correctly, because the theory is that the malignancy is going to spread by the portal route. So if you can remove the entire section with its portal flow, then the chances of recurrence post-surgery is going to be less. So after marking the area of the dye, spread along the portal route, the cautery marks along that particular segment was made, and then the entire segment is removed surgically. The Alice model, basically what they have done again in this Alice model is they have combined the two, that is the indocyanine green retention rate at 15 minutes along with albumin, and they have found that this is a better method of understanding whether the patient can be taken up for liver resection and whether the patient is going to have a good functional reserve after hepatectomy. And this was found to be of use in patients with child A CTP situation. So this busy slide actually is telling us the same thing which we just talked about. And it tells us regarding Makuchi's criteria for safe hepatic resection. That is, if there is ascites present, which is controllable ascites with the bilirubin of varying levels, in a controllable ascites with bilirubin of varying levels. So these are the various kinds of hepatectomies we can go for. And of course, if the bilirubin is more than 2, then no hepatectomy is advised. So depending on the various bilirubin levels, then if ICG R15 is normal or has varying levels, these are the surgeries which can be recommended. And in the Alice grading also, you have the 3 grades there: Alice grade 1, grade 2, and grade 3. Which again will tell us as to what is the extent of hepatectomy, what kind of liver surgeries can be done for the various 3 grades. Yeah, so the other features which have been looked at is understanding if the patient has fibrosis or not, because that is what is going to determine what the future liver remnant should be, whether it can be accepted as 20% or 30%. If the fibrosis is significant, even if not in the cirrhosis range, then you would go for 30% of FLR there. And the other modalities would be of finding out fibrosis would be doing the APRI score, the FIB4 scores, but these are not validated completely. Elastography, of course, as I just said, and as has been talked about by Dr. Hema, should be done to understand the degree of fibrosis, to understand if it's advanced fibrosis or not. Calculation of the remnant contrast enhancement ratio after enhancement with the hepatocyte-specific contrast agent has been reported to provide not only information on liver tumor, but also combined anatomical quantitative liver functional information. This is found to be better than the simple gadolinium DTPA scans, which we do for MRI. And in cases of situations like presence of steatosis, fibrosis, and cirrhosis, where the liver function might not correlate well with the liver volume, technetium 99 GSA can be used for metabolic assessment of the whole or partial liver function. Also suggested to be useful in patients who have undergone portal vein embolization or ALPPS. So to understand microvascular invasion, whether it is present or not, the best modality, of course, is histopathology. That is, it gives you the 100% confirmatory diagnosis whether it's present or not. However, it is also good to have an idea regarding whether there's a high possibility of a tumor having a microvascular invasion. And these are the parameters which give us that indication: a tumor diameter which is more than 2 centimeters, multiple tumors, an incomplete tumor capsule, the presence of typical dynamic pattern, a high AFP level. And implication is that if there is a microvascular invasion, then the post-operative adjuvant-based treatment has been recommended so as to prevent recurrence of tumor after hepatectomy. And lastly, this was an interesting point to talk about, that serum iron has been now regarded as a negative factor for survival post-surgery, a level of less than 94 micrograms per deciliter. And hence, supplemental iron has been recommended prior to surgery. While liver iron stores are negatively associated with the outcome, but serum iron, if it is low, then it is again negatively associated with the outcome, and it is better to give iron prior to surgery. That concludes my talk on assessment pre-surgery for resection for purposes of HCC. And I would welcome any questions if there are. Thank you.
So we have seen two things. So one is, mainly the identification of portal hypertension. That is clinically significant portal hypertension, those with advanced liver disease. The second part is those who are going to undergo liver resection. So like in HCC, and how we can predict the post-operative liver failure. That is the only thing we are worried. The main thing is to rule out whether there is a clinically significant portal hypertension or not. So how we rule out clinically significant portal hypertension is with the liver test, the liver routine liver function test, and whether we can do imaging and then all the other things like ICG and what all things we can use to predict. So earlier we used to, if the platelets are like normal, the liver function, the albumin is normal, there are no varices, we think that, yeah, they are good to go for the liver resection. Yeah. So now we are getting more refined. So if there is a suspicion of, cirrhosis, then HUPD, yes. If it is less than 10, we boldly go. Or, if there is a possibility, like you say now that a portal hypertension is not a contraindication, that means we need to quantify the portal hypertension.
Portal hypertension.
So we need to quantify that, then HCPG comes. And then some surgeons also take biopsy of the uninvolved liver. So to see if there is, any advanced fibrosis or not. So then, because that will preclude them from resection. So there, this elastography has been used. So the fibroscan cannot be used there because it is just done at the right. So using the shear wave, the ultrasound based, so there they can go and localize which area they can. So it is a area can be picked up, especially non-involved area, and they can look and compare the stiffness between the tumor area and the non-tumor area. So especially, if you don't have the HUPT, so, there is the platelets are normal, there is no varices, and then you can use this elastography instead of a liver biopsy. So this is so when it comes to a liver resection, so we can use elastography to rule out. So there is always a ruling in and rule out, because there is in between, there is a gray area. So to rule out cirrhosis, yes, it is a good. So if it is in this extreme, lower extreme, it's good to rule out. But the gray area, again, we'll have to go for HCPG or a liver biopsy.
Yes.
More and more. And we are now doing it for, HCC resection. Yes. Now we are doing it for almost all patients, for donors, living donors, liver donors. Earlier we used to do for, liver biopsy. But now for, especially if the BMI is between 25 and 30, above 30, we do biopsy for all patients. But if the BMI is between 25 and 30, then we can use this elastography to, assess if there is any degree of fibrosis or not. So if we do the elastography and if we see that the stiffness is 6, then there's nothing to worry. Whereas if it is like 8 or 9, then probably we will subject them to biopsy. Yeah, Nisha?
Yeah. No, I was losing you in between, so it got cut. Yeah, I lost the connection.
Somebody has asked a question. How is serum iron related to the prognosis, Nisha?
Yeah, so that is what has been seen, that if it is low serum iron, they have found that there is a poorer outcome of the patients. So I think it would be something to do with the inflammation and all post-surgery. So, that is why the recommendation, though it is still not proven, it's not hard proven. So it's still under study. It's not a part of the protocol of workup, but it is one of the things which I found was interesting. So I just put it there as a thought that, it's still under study, that as to whether serum iron really needs to be evaluated or not. Well, most of the cases anyways, post-surgically, I think you would prefer to have a low serum would be associated with low hemoglobin, and that would be associated with a low surgical outcome, especially when we are talking about liver resections and also. Yeah. Would you have any other insight on that?
No.
Since you're primarily into transplants.
Yeah. So no, I think the low serum overall looks at the nutritional status, so I think that should be
that's what I also thought, that,
be the one, because
I don't think it should be a strong pointer really to, accept or not accept patients really. But I think this is very interesting that, fibro, elastography can be done pointedly, and you can make out that whether the remnant part of the liver is normal or not, because that gives you a wider berth for doing the surgery. Because fibroscan can give you a higher false high results, when you are doing it, especially if the tumor is larger. So it's not really reliable in those situations. Luckily, most of the patients now are being referred to liver transplant centers. So at most of the liver transplant centers, we do have HVPG facilities. It's not only in the smaller places, like, a patient has simply ruled out possibility of a liver transplant where you would be taking up such patients for liver resection. Yeah.
But anyway, if it is a resectable lesion, definitely resection should be offered than transplant, I would say, unless it is a decompensated disease. I think if it is a resectable lesion, the patient should be offered resection, because transplant is also, it's not a normal life. It's still another liver, and you have to be on it.
Agreed.
If it is a resectable lesion, there is no portal hypertension, the residual liver is normal, still the resection should be offered first. Of course, there is a risk of recurrence. He needs to be on follow-up, but still we should offer a resection.
There is again a lot of gray area here, because there are a lot of studies regarding whether resection should be offered in these patients, or whether you should go for the non-surgical techniques. As a gastroenterologist or hepatologist, when you think about resection versus non-surgical, because I'm not a surgeon, so when it comes to making a choice between a surgery and a non-surgical thing, where that the chance of recurrence might be there, especially in a cirrhotic patient who is a compensated cirrhotic patient, the stage 0 or stage 8. What would you go for, like, in a patient like that? What would your recommendation be? Because I think here the patient choice does is to be taken into account. Resection, of course, is like, it gives you a clarity that, okay, the entire thing will be out. But then most of the studies have shown that stage 0 gives almost the same results with both the modalities.
So when you're saying non-surgical modality, you mean you're talking about PI?
Yeah. We're talking about PI, RFA, yeah.
So when we're talking about curative options for HCC, it is going to be either RFA or resection. Okay, so TACE is not considered curative.
Not TACE, we're talking about RFA and PI, yeah. Radiofrequency ablation.
So radiofrequency ablation is curative only up till 2 to 3 centimeters. Beyond that, it is not curative. So any lesion beyond 3 centimeters, if it is resectable, we should resect. If it is not resectable for various reasons, it's a cirrhotic liver, or so then we can go for a TACE, which is still considered a palliative procedure. That means the survival is definitely prolonged, yes. We might be able to downstage it, yes, but it is not considered a curative procedure. Like RFA within 3 centimeters and or a resection procedure. So we need to understand that very clearly. So
actually, so that is what narrows it further down, because till 2 you could still go for either, but then between 2 to 3 resection is what is advised. So it actually narrows down the field of resection. If you talk about only resection is the treatment which is available for this particular situation, this is the only way to go. So it actually narrows it further. But yeah, I mean, given a choice, one would always say that go for resection. Yeah.
If possible, that's the best option. Yeah. So does Hisky have any questions? So you can see how all the horizon for elastography is widening. It has to be a lot more. We need to still do a lot more work on it. How to use it in a much more focused way. But horizon is widening definitely. And we need to have more studies in Indian patients, compared to the number of patients, NASH patients we see, how they are progressing over the years. So,
especially, yeah, it's very important, especially because their liver enzymes and all will be totally normal. And so far, people have been brushing it under the carpet, that it's not really a big disease, only that we see them when they are full-blown cirrhotics. So yeah, I think it's very important to pick up these patients who do not have very high levels of enzymes to begin with. Yeah.